Can we start? Assalamu alaikum, good afternoon. Because of the program that been delayed for this 30 minutes, so I would like to welcome all of you, and we'll start our uveitis sessions, mysteries and challenges. I will start with my first case. Is it VKH or not? As you know, sometimes even that you are expert, you get in the case, and for uncertain that might be you are not sure about your diagnosis. Could I move the slides, please? Yes. So I will start with this patient, 25-year-old, healthy male that presented with sudden defective vision, both eyes for 2 days. Examination of this patient showed that visual acuity of 2200 in both eyes. Intraocular pressure was within normal, anterior chamber deep and quiet. And upon the examination of the fundus, you see this ugly looking fundus with multiple areas of excessive retinal detachment. So our first things that to put it in our mind is to go more and more in deep in the history. The patient is having headache and no history of fever or tinnitus. So at this stage, we put our primitive diagnosis as VKH and we work in that. So the patient being admitted, and this is his autofluorescent. As you see, there is an areas of hyper autofluorescent corresponding to the area of the excessive retinal detachment. Doing the fluorescent angiography of this patient, this is the OCT. As you see, there is multiple area of neurosensory elevation with subretinal fluid, and there is some sort of internal limiting undulations as well in these situations. The fluorescent angiography showed pinpoint areas of hyperfluorescent, and even though some areas of pooling, but here we didn't see even though the hot disk or hyperfluorescent of the disk, which is unusual for cases of VKH. So based on what we have, we're starting the patient after primary investigation, ruling out tuberculosis, syphilis, hepatitis. We started patient in IV methylprednisones, and after 3 days dose of 1 gram of methylprednisone, the subretinal fluid is getting less and less, and then the patient discharged and going home an oral prednisone and starting to have some sort of sulcet. And 1 week after, we found these pictures where all the subretinal fluid increase, and even though the excessive retinal detachment increase. This is give us the chance here to think, are we dealing with VKH or something else? So what will be the other alternative diagnosis here? Is it CSR? Because we're starting in IV methylprednisone, which might be provoke the CSR situations. So even though we repeat the fluorescent angiography and the picture now a little bit modified, even though the disc is not that hot. We did an ICG, didn't show the classical pictures of VKH. So after that, we send the patient to have 1 more clarifications. Can you please put the slides? Clarification, and we did the confirmatory. Can I move, please? We did the ICG, which really clearly saw that our thought. It is VKH with multiple areas of choroidal granulomas. And this cannot be with central CSR. So the patient starts again in a course of 5 days. And after that, see the picture, how much now it's beautiful. So this is a case of incomplete VKH and could be sometimes confused with CSR. Approximately 22% of the patient diagnosed with VKH disease were mistakenly identified as a case of central CSR. The treatment approach for these diseases vary significantly, since the primary treatment options in VKH is corticosteroid, which may deteriorate the clinical course of the patient with CSR. The message is here: be careful when you are evaluating patient and use the multimodal imaging for this patient to make sure all of this. I will not go because the times that short for that, and I will jump to the conclusion. So VKH and central serous chororetinopathy, distinct pathophysiological process, exhibit some shared clinical characteristic and different treatment approach in both sides. So multimodal imaging serves as valuable tools for confirming diagnosis of VKH or CSR when the clinical diagnosis is unclear. Make more precise and timely treatment decision. Thank you for your attention, and we'll open it for discussions.
Thank you, Dr. Hassan. Why at the beginning you were suspicious it's not a VKH?
Yeah, clinically, was it's okay with VKH because incomplete, the patient doesn't have tinnitus or
Headache or
non
tinnitus or
engagement,
any
okay.
neurological manifestation, you
Yes,
mean?
but when I did the fluorescein angiography, what's happened that if in the disc is not leak, and you know the revised international
Yes.
criteria, it's typically of that. So here the situations, what will be? VKH is some sort of autoimmune disease. Is there anything that could be get in, and is it CSR or not? Because sometimes the same age, the same situations, and after starting the IV methylprednisone, the situation is getting worse. So what will be in your mind here?
But let me think with you again. If it is exudative detachment, it's not the typical picture of CSR. But if it's exudative detachment, I will go through the choroid. I will see what's underlying. Could be choroidal scleritis, multifocal choroiditis, apart from VKH. But why she got worse with the steroids? This is the question.
This is we don't know. Is that because this is an acute onset VKH, so starting still not in the peak of the disease itself?
How long you gave her steroids?
We gave it first time 3 days.
3 days, and then you
Then
stopped,
we shifted to oral steroid.
and still getting worse.
After 1 week of follow-ups,
Yes,
you see the OCT is getting
I've seen that.
yeah.
Maybe she was not compliant. I mean, I've never seen a patient not responding to steroids. I mean, if you give a full dose according to the weight and then you continue, I mean,
I agree with you, but sometimes you know that corticosteroid, when getting in the in the blood of the patient, sometimes the protein,
takes time.
yeah, so that might be not adequate therapeutic dose, or
Yes,
might be we are not reaching the times where that medication is adequate.
I see.
For that reason,
Yes, it could be. But
although
what?
there is an initial response
Yes,
after
I
and
mean,
then
it's
getting
it's the usual case. I mean, if it's a VKH and responding, and you proved it's a VKH, it's very unusual that she will not respond to steroid. You give mega dose or you give oral from the beginning.
we give IV
Intravenous.
intravenous, yeah. This is our protocols for VKH.
Yeah, so
But that's make me might be the patient sometimes might you have a patient with VKH and
yes,
in the same
yes,
times
yes.
is a central serous يعني
The only misleading thing is aggravation with steroids. That's why you shifted to CSR. But again, if you continue the steroid,
for that reason the key point here the ICG.
yes. Yes,
ICG should be done in this
and
case.
CSR also, this is another point. Fluorescein angiography would have shown that if it's a bilateral CSR with this aggressive picture
Yeah,
of fluid,
but
CSR would be manifest on fluorescein angiography. The point of leak, there is
it's
nothing
okay, but
leaking
you
in
would
the
like
retina.
to make sure that to look for the choroid with ICG.
Yes.
It's typical, except the patient is having tuberculosis or sarcoidosis,
Yes.
but not will come as exotic like that.